Gastrointestinal bleeding. General statistics of GI bleeding show that 3 of 4 cases originate in the upper GI tract from the tip of the nose to the ligament of Treitz. 1 of 4 originates in the colon or rectum, and very few arise from the jejunum and ileum. GI bleeding arising from the colon comes from angiodysplasia, polyps, diverticulosis, or cancer, all of which are diseases of old people. Even hemorrhoids become more common with age. Thus, when a young patient has GIT bleeding, the odds are overwhelming that it comes from the upper GIT tract. When an old patient bleeds, it could be from anywhere. An equal opportunity bleeder, as the upper GI is the most common source overall 3 of 4, but age makes that old patient a good candidate for lower GI bleeding. Statistics are helpful when the bleeding is per rectum, but they are not needed when patients vomit blood. Vomiting blood always denotes a source within the upper GIT tip of the nose to the ligament of Treitz. The same is true when blood is recovered by NG tube in a patient who shows up with bleeding per rectum. The best next diagnostic test in that setting is upper GI endoscopy. Be sure to look at the mouth and nose first. Melena black, hairy stools always indicates digested blood, thus it must originate high enough to undergo digestion. Start workup with upper GI endoscopy. Red blood per rectum could come from anywhere in the GI tract including upper GI, as it may have transited too fast to be digested. The first diagnostic maneuver if the patient is actively bleeding at the time is to pass an NG tube and aspirate gastric contents. If blood is retrieved, an upper source has been established, follow with upper endoscopy. If no blood is retrieved and the fluid is white, no bile, the territory from the tip of the nose to the pylorus has been excluded, but the duodenum is still a potential source. Upper GI endoscopy should follow. If no blood is recovered and the fluid is green bile tinged, the entire upper GIT tip of the nose to ligament of Treitz has been excluded, and there is no need for an upper GIT endoscopy. Active bleeding per rectum, when upper GI has been excluded, is more difficult to work up. Bleeding hemorrhoids should always be excluded first endoscopy, but colonoscopy is not helpful during active bleeding. The oncoming blood obscures the field. There are 2 ways to go after the hemorrhoids have been excluded. Some practitioners proceed according to the estimated rate of bleeding. If it exceeds 2 ml minimum 1 unit of blood every 4 hours, they do an angiogram, which has a very good chance of finding the source and may allow for angiographic embolization. If the bleeding is less than 0.5 ml min, they wait until the bleeding stops and then do a colonoscopy. For the cases in between, they may do a tagged red cell study. If the tagged blood puddles somewhere, an angiogram may be productive. The curse of the tagged red cell study is that it is a slow test. By the time it's finished, the patient is often no longer bleeding, and the subsequent angiogram is useless. In that case, at least there is some idea if the puddling is on the right or the left and could thus guide a potential blind hemicolectomy in the future. If the tagged red cells do not show up on the scan, a subsequent colonoscopy is planned. Some practitioners always begin with the tagged red cell study, regardless of the estimated rate of bleeding. Patients with a recent history of blood per rectum, but not actively bleeding at the time of presentation, should start workup with upper GI endoscopy if they are young. Overwhelming odds, but if they are old they need both an upper and a lower GI endoscopy at the same session. Blood per rectum in a child should be from mecal diverticulum. Start workup with technetium scan, looking for the ectopic gastric mucosa. Massive upper GI bleeding in the stressed, multiple trauma, or complicated post-op patient is probably from stress ulcers. Endoscopy will confirm. Angiographic embolization is the best therapeutic option. Better yet, they should be avoided by maintaining the gastric pH above 4. GI bleeding in someone with an aortobifemoral polyester graft is most likely a very serious condition called aortoenteric fistula.